Welcome back to another rapid-fire revision deep dive. And this one is tailored specifically for you, the resident preparing for the FRCS Plastic Surgery Board exams. I mean, we are getting straight into it today.
Absolutely. No messing around.
Right. So today's mission is laser-focused. We are breaking down the principles and techniques of total body contouring, and we're really specifically dissecting the highly tested components of the body lift.
Yeah, because this is an area where examiners, they demand absolute precision. I mean, they're not looking for vague concepts here.
No, not at all.
You're expected to demonstrate a really solid three-dimensional understanding of the anatomy, the specific surgical classifications, and the biomechanical consequences of your choices in the OR.
Exactly. Before we throw you into the hot seat with the first Viva scenario, just a quick reminder to hit follow on the show right now so you don't miss our upcoming revision deep dives.
Yeah, you really don't want to miss these.
And if you learned something valuable today, take a second to rate the show. But most importantly, and I mean this, if you want to actually lock this high-yield knowledge in, head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck.
It's honestly a lifesaver.
It has over 6,000 questions arranged by topic to help you actively recall the key facts, and it's all based on the textbook Keynotes in Plastic Surgery. So definitely go grab that.
Because active recall is it's the only way to survive these boards.
Right, which is why we're doing a direct, no-nonsense, question and explanation style interview today.
Maximize that study time.
Exactly. So let's set the stage here. We can't even touch the complex named surgical classifications until we get the basic definitions down.
Yeah, you have to build the foundation first.
Right, so if an examiner asks you to just define a body lift, you can't treat it as some generic thing.
Oh, no. Using that term without qualifying it in an exam, that's an immediate red flag.
It really is. You have to clearly delineate the boundaries.
Yeah.
So, upper and lower components. Let's simulate that pressure right now. I'm going to act as the examiner.
All right, I'm ready.
And for you listening, try to formulate the answer in your head before we give it away.
Ah.
So, what four specific surgical procedures make up an upper body lift?
Okay, so in a Viva, you want to be methodical here. Component number 1 is the reverse abdominoplasty.
Right.
Component number 2 is the upper back lift. Component number 3 involves reshaping and augmenting the breasts. And then component number 4 is the brachioplasty.
Okay, so that's reverse abdominoplasty, upper back lift, breast reshaping and augmentation, and brachioplasty. All four.
Yes. It's absolutely vital that you recall all 4 to get the full marks.
Let's analyze the logic there, because just memorizing 4 random procedures is a nightmare.
Yeah, it doesn't stick.
But if you understand the anatomy, it's intuitive. Like if I'm visualizing the patient, I'm thinking about a continuous ring, like a cylinder of surgical tension around the upper torso.
That's exactly how you should conceptualize it. You're addressing that upper truncal cylinder. So the reverse abdominoplasty, that handles the redundant tissue of the upper anterior abdomen, right? By pulling the skin flap superiorly.
Right. And then that superior pull logically meets the inframammary fold.
Exactly, which seamlessly integrates into component 3.
Reshaping and augmenting the breasts.
Right, to manage that anterior chest envelope. But to keep that circumferential control, the tension has to wrap around to the back.
Which is component 2, the upper back lift.
Yep. That takes care of the posterior brought roll redundancy. And then finally, you can't leave the upper limbs unaddressed when someone has had massive truncal weight loss.
So that brings in the brachioplasty, component 4.
Exactly. Extending the contouring laterally down the arms.
So it all links together perfectly once you see that mechanical cylinder.
It really does.
Let's pivot and move inferiorly.
Yeah.
The lower body lift. And to make this stick, let's use a spatial analogy for the listener. Think of the surgery moving from the front to the back to the inner legs.
That's a great way to map it out. So following those 3 regions, the 3 parts of a lower body lift are, first, the abdominoplasty.
Managing the front.
Right. Second is the lower back lift. Yep. And third is the medial thigh lift.
Which manages those inner legs.
Exactly. So abdominoplasty, lower back lift, medial thigh lift.
Abdominoplasty, lower back lift, medial thigh lift. Okay, let's pause right there. Let's isolate just the truncal elements of that list. So the first 2.
The abdominoplasty and the lower back lift.
Right, because this introduces a highly testable distinction that catches people out every single year.
Oh, yeah. The examiners love this trap.
So if you just combine the abdominoplasty and the lower back lift, what is that called?
That specific combination is collectively known as a belt lipectomy. Or you'll also hear the synonymous term circumferential abdominoplasty.
Belt lipectomy or circumferential abdominoplasty. So If a multiple choice question asks me to define a belt lipectomy, I am strictly talking about that truncal cylinder.
Strictly the trunk, yes. The defining characteristic of a belt lipectomy is that it remains on the trunk.
So the moment you add the medial thigh lift,
You've structurally upgraded the whole procedure. It's not a belt lipectomy anymore. The addition of the medial thigh lift transforms it into a full lower body lift.
and that's the trap. They'll ask for the components of a belt lipectomy, and one of the distractor answers will confidently list a medial thigh lift.
And you just have to know to avoid it. The medial thigh lift is the differentiator.
Okay, so we've got the foundational definitions locked in, 4 components for the upper, 3 for the lower, and we know what a belt lipectomy is.
Right.
Now that we understand these massive zones of tissue, the next hurdle is how we actually combine these lifts in real life without ruining the patient's anatomy. And that brings us to the named classifications.
The Lockwood classifications.
Right, the stuff examiners absolutely love.
I mean, Lockwood is the foundational name you just have to associate with lower body contouring. He realized that just cutting away skin wasn't enough.
You actually have to manage the tension.
Exactly. He developed specific approaches to anchor the superficial fascial system.
So I'm going to ask you to outline the 2 different types of lower body lifts described by Lockwood. But I want to push you on this a bit.
Okay, go for it.
In a Viva scenario, if the examiner asks which of these 2 types is the standard go-to in modern practice, I need to know the correct indication, not just the history.
Fair point. To get to the indication, we have to look at the mechanical differences. So Lockwood described lower body lift type 1 and lower body lift type 2.
Let's start with type 1. What are the specific components?
Type 1 consists of a medial thigh lift combined with a transverse flank, thigh, and buttock lift.
Okay, medial thigh lift plus a transverse flank, thigh, and buttock lift. That makes sense mechanically.
Right, you're addressing the inner thigh and then using a massive transverse excision to lift the lateral flank, the outer thigh, and the posterior buttock.
So contrast that with lower body lift type 2.
Type 2 shifts the whole mechanical approach. It consists of a high lateral tension abdominoplasty combined with just a transverse thigh and buttock lift.
Wait, let me stop you there because we need to challenge that logic for the listener.
Sure.
Let's look at them side by side.
Sure.
Lockwood 1 uses a medial thigh lift and explicitly includes a transverse flank lift.
Right.
But Lockwood 2 swaps in a high lateral tension abdominoplasty and just completely drops the flank component.
Yes, it drops it.
But if we abandon the flank lift, aren't we just leaving a bunch of sagging, redundant tissue on the patient's sides? Why drop it?
And that right there is the exact biomechanical leap the examiner wants you to vocalize. You aren't leaving redundant tissue. You're just managing it through a different tension vector.
Okay, how?
The secret is the high lateral tension part of the abdominoplasty. Instead of just pulling the abdominal flap straight down, you anchor the superficial fascial system deeply and laterally.
Oh, wow. Okay, so by creating that intense lateral tension, you're effectively sweeping that flank tissue forward and down.
Exactly. Sweeping it anteriorly and inferiorly. It does the work of the flank lift without actually needing a separate transverse flank excision.
That makes so much sense.
And that lateral fascial anchoring stabilizes the whole contour, which actually answers your first question about clinical indications.
Right. Which one is the standard go-to?
Because of that superior tension management, lower body lift type 2, the high lateral tension abdominoplasty combined with a transverse thigh and buttock lift is unequivocally the indicated procedure in most circumstances.
The listener needs to lock that fact in right now. Type 2 is the standard indication.
Yes. For multiple choice questions or the Viva, bypass type 1, go straight to type 2.
Okay, so this brings us to, I think, the most critical synthesis of this entire deep dive.
The biomechanics.
Right. Because the choice of these techniques dictates exactly where the surgical scar is going to sit on the patient's body, and that introduces aesthetic trade-offs.
The classic clinical dilemma. Examiners want to see that you understand the physical consequences of where you place those incisions compared to, say, traditional methods.
So let's frame this as a synthesis question. The examiner says, compare the aesthetic outcomes and scar placement of a Lockwood lower body lift versus a traditional belt lipectomy.
It's a great question.
And to make the biomechanics stick for you listening, I want to use an analogy. Let's compare it to pulling up a really tight pair of trousers.
I love this analogy.
The waistband of the trousers is our continuous scar. Where you anchor that waistband dictates what gets flattened down by compression and what actually gets pulled tight.
Perfectly isolates the tension vectors. So let's start with the Lockwood scar placement.
Okay.
The Lockwood scar is placed relatively low on the buttocks. So in your analogy, this is like letting that super tight waistband sit low on the hips.
Right across the gluteal region. So if we anchor it low, what's the mechanical consequence?
The clinical drawback, and you have to explicitly state this to the examiner, is a buttock flattening.
Wow, really?
Yes. Because the scar is anchored low, the tension vector pulls taut directly across the maximal projection of the glutes. Suturing that low tension physically compresses the tissue plane.
It flattens the buttocks, which sounds like a terrible aesthetic outcome.
It often is highly undesirable for the patient.
So why on earth would Lockwood design a procedure that flattens the buttocks?
Because he was prioritizing a different zone. Think about a massive weight loss patient. They often have severe, debilitating laxity of the thighs.
Right, the thighs are usually the primary complaint.
Exactly. So by placing the scar low, you are physically closer to the thighs. That low anchor gives you maximum direct upward pull on the thigh tissue.
I see. So the flattened buttock is just the mechanical cost of getting maximally tight thighs.
That's the trade-off.
That is brilliant. Low scar equals tight thighs, but flat glutes. So contrast that with the traditional belt lipectomy scar.
The traditional belt lipectomy scar is placed significantly higher. It sits on the true waistline.
So pulling that tight waistband all the way up to cinch the midsection?
Exactly. And because the anchor point is high, the tension vector sits entirely above the gluteal region.
So it doesn't compress the buttocks at all.
Not at all. It completely preserves buttock projection. Plus, that high tension successfully accentuates the contour of the waist.
A cinched waist and natural gluteal projection. Sounds like a win-win.
Aesthetically, it looks fantastic. But as we know, there are no free lunches in surgery.
What's the cost of the high scar?
The cost is distance. Because the scar is high on the waist, it's physically much further away from the thigh tissue.
So the tension vector just runs out of steam.
Exactly. It dissipates before it can effectively reach the lower extremities. So the higher scar has significantly less of a tightening effect on the thighs.
Okay, let me quickly summarize this dynamic, because this tension management is the absolute crux of the whole topic.
Go for it.
If you use a Lockwood lower body lift, the scar sits low. That gives you powerful tightening on the thighs, because it's closer to them. But the inescapable trade-off is that it compresses and flattens the buttocks. Conversely, if you use a traditional belt lipectomy, the scar is high. You get a great waist contour, you preserve the buttocks, but the trade-off is distance. You lose that mechanical advantage, so you get less tightening on the thighs.
That synthesis is exactly what the board wants to hear. You can't maximally tighten the thighs and maximally project the buttocks with a single continuous scar.
It's just a physical impossibility. Pull the waistband high, your waist looks great, glutes project, but the pant legs are loose. Pull it low, the legs are tight, but your glutes are flattened.
You have to choose your priority based on the patient's specific anatomy and goals. Demonstrating that logic proves you aren't just reciting a textbook.
You're actually anticipating the post-operative reality.
Exactly.
All right, before we close out, I want to leave you, the listener, with a final provocative thought to mull over during your prep.
Yeah, think about this when you're doing your revisions. Picture yourself consulting with a massive weight loss patient. They have profound thigh laxity, but they also desperately want a projected aesthetic gluteal contour.
Which they all do, of course.
Right, so how does this inverse relationship between thigh tightness and buttock projection, which is dictated entirely by your scar placement, how does that fundamentally shift your entire surgical plan?
It changes everything.
It does. How does it alter those difficult conversations you need to have during the informed consent process?
Because if you don't explain that mechanical reality up front, they're going to be that exact patient returning to your clinic 6 months later, asking where their gluteal projection went.
And you don't want to be in that situation. That's the kind of consequence-based thinking you need for the FRCS.
Absolutely. Well, that is our time for today. To maximize your revision, head over to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck.
Seriously, go get it.
And before you jump back into your clinical duties, leave a comment or a question about today's material on whatever platform you're listening on right now. Keep grinding, and we'll see you on the next deep dive.